Hello, and welcome to this episode of A Cancer Conversation with the Georgia Cancer Center at the Medical College of Georgia at Augusta University. Thank you for taking the time out of your day to watch and or listen to this conversation. My name is Chris Curry, and I am the host for A Cancer Conversation. I work at the Georgia Cancer Center as the manager for communications and marketing. And today I am joined by Dr. Justin Xavier Moore. Dr. Moore is an epidemiologist with vast skills in biostatistics, epidemiology, database design, geographic information systems, mediation analysis, and cancer prevention and control. So that is quite a list of skills there, sir.
Yes. I like the shorter version, which is I'm your own personal epidemiologist. And basically what that means is I'm a scientist that explores how and why people get sick and try to prevent that from happening. And with me focusing on cancer, I have a particular focus on preventing cancer disparities and cancer outcomes or cancer morbidity and mortality.
And I see that some of your specialties when it comes to cancer, breast cancer, lung cancer, and early onset colorectal cancer. Is that right?
Yeah, so particularly my research focuses on breast cancer outcomes. I've done a few studies that have focused on lung and early onset colorectal cancer. In short, my research theme focuses on the intersection between place, so where someone lives, their environment, where they work, and race, or I like to call it race, parentheses, ism. So the influences of systemic and institutionalized racism on people. And how that interaction, right? So societal, structural issues, right? Your environment, how they interact, and then how they influence your outcomes. And oftentimes what I see in a lot of the work that I do is that regardless of whatever the outcome, you can put breast cancer, you can put colorectal, you can do lung. Heck, we even looked at COVID-19.
Okay.
You see some of the same disparities. And oftentimes we ask why. Right? There's a lot of things that are happening well before someone even goes to the hospital, well before they're diagnosed with the disease that predict or that cause this imbalance in outcomes. And that's a lot of the work that I do.
Why were you interested in this? What led you down this career path?
Okay. So that's a great question. All right, so for many epidemiologists, I'm not going to speak for everybody else, but I'll speak for me.
Uh-huh.
This is something that's prevalent among a lot of the epidemiologists that I know.
Okay.
So as a kid, one of the things that I was always interested in was math and science. I'm the oldest of 5 children and 10 grandchildren, so I've always had like a lot of responsibility. And with my mom suffering from a variety of different mental health disorders, like I was always like her nurse or like trying to take care. I was always a caretaker, basically. And with me being really, really good at math and science, like I knew that I wanted to be a doctor. But the thing is that I grew up in an environment where I didn't necessarily have that many near peers or mentors who were in health sciences or medicine.
Okay.
Right? So I just knew I wanted to be a doctor. I knew I wanted to be a scientist. I knew I
Okay.
was smart enough to do something. I know I wanted to help people, and I had so many people around me within my own family succumbing to certain diseases at such an early age, right? I would like my granddad died from hepatic cellular carcinoma or liver cancer,
Okay.
like, right in front of me, and I'm like, this was the person that inspired me to do really well in math and science, and I remember seeing him on his hospital bed and him not even know my name, right? So for me, it was the curiosity and like what's going on here for so many people that look like me that are disproportionate. Of course, I didn't have these words at the time, but the disproportionate, to me, it just seemed it was way too soon, right?
Yeah.
My granddad, it was in his 50s.
Oh, wow. That
right?
is young.
Yeah. So, like, again, you're looking at it, you're like, okay, this just doesn't seem right.
Yeah.
Even my dad died when I was 8, the next year,
Okay.
actually, and he was in his early 40s.
Oh, wow.
Right? So, again, I developed this curiosity for science and medicine, and I knew that I wanted to go to be a doctor of medicine.
And that's
That's
a really
all I knew.
wide field.
Yeah, that's all I knew. That's all I knew. So ended up going to undergrad. I went to a very non-traditional undergraduate institution called Hampshire College.
Okay.
And it really, really pushed me to become even more so of a critical thinker. When I say it's non-traditional, we didn't have traditional grades. We had narrative evaluations, which meant that you would take a very rigorous course where you're like reading whole chapters and books every night, and you're doing many thesis projects all the time, right? So it was very rigorous.
Sounds intense.
And then instead of getting a grade, you had a professor that would write up a whole like evaluation of how you perform. So it was like little recommendations.
So instead of grades, you called it a narrative
evaluation.
Okay.
Right. And I had to do a senior thesis to graduate. 80 pages, and it focused on neuropsychology, mental illnesses, and looking at complementary and alternative approaches. And that was like my first, I guess, step into research. Mm-hmm. And then once I graduated, because of being in a non-traditional institution, I was like, you know what, I need to go and do something less post-bac, or I need to do some more education or more training, because most of the medical schools are not looking at your transcript like, what are these evaluations?
These are not A's and B's.
Yeah, I did go to other universities and take like other chemistry and physics and whatever, and did really well. It's just that for the bulk of your work, they're not going to read that and really be, trying to help. Like, you really need to have like a traditional transcript in order to get it. So I enrolled I had a mentor. And I'm sorry for telling such a long. I had a mentor that was at Brown.
Stories are good.
Yeah. I was in New England. I had a mentor at Brown, and she was at a medical school, and she was like, you know what? You should look into a master in public health and epidemiology. Okay. And that changed my life. Okay. I mean, ever since then. So I remember applying to a few programs. I got into UAB, got into some out on the West Coast. West Coast was way too expensive. I was like, I'm going back to the South because I'm tired of this cold weather.
So did you grow up in Georgia?
Grew up in Georgia. Yep. So went to UAB, stayed there for 5-6 years, did my MPH and my PhD, and fell in love with epidemiology. Okay. I like to tell people that when you think of a traditional MD, they treat patients. They treat person by person. Mm-hmm. But for epidemiologists, we get the opportunity to look at population health and try to help entire groups of people through our science. And I think that with the COVID-19 pandemic, more people are exposed to what epidemiology do.
Absolutely.
But even still, like I'm always trying to explain.
Well, let's do that. Yeah. What does an epidemiologist do exactly? What does a typical day in the life of Dr. Justin Xavier Moore look like? So, okay, that's a great question. All right. So I'm going to tell you what I do, and then I'm also going to tell you there's a wide variety of what epidemiology is. Okay, and different types of work. So it depends on where you are. Okay. You have some epidemiologists that are like social epidemiologists, geospatial epidemiologists, clinical epidemiologists. Like, you can almost put, you can be a genetic epidemiologist. Okay. It's more so of what field of science and disease you're interested in. Okay. I classify myself as like a cancer social epidemiologist. Okay. Which means that I focus on cancer as an outcome, and social epidemiology means that I focus on, again, risk factors in terms of the social determinants of health lens. The race and place that you talked about. Yes. So a day in my life, in terms of, it could be a wide variety. As an epidemiologist, a lot of times we deal with data. We have numbers that are based on medical records, death certificates, data from the CDC, surveys, all of these different avenues of collecting data. I can actually go out and collect my own data. Okay. Quantitative data is the most prevalent form. Okay. When we say quantitative, we're talking about numbers that are derived through, again, surveys or some type of record collection. Okay. But then also, as a social epidemiologist, I really, really wanted to get more involved in the community, right? So there's one thing to look at trends and how outcomes and things are kind of spread throughout populations, right? So we can look at, 1 out of 5 people are going to be diagnosed with a certain type of cancer. Mm-hmm. That data, those statistics are derived from epidemiologists collecting the information and then running some type of analyses. Okay. But that's one thing to just look at what the problem is.
I'm a firm believer in doing something about it. So another theme of my work is community-based participatory research or community engaged work, where I partner with local community stakeholders to try to disseminate some of the information that we do have about certain health outcomes. For instance, I have a NIH grant that is a KO1, which means it's a Career Developmental Award to do some of my own research and explore. And it focuses on geographic and racial disparities in mammography screening and barriers to receiving care.
Okay.
So within that project, I have the quantitative piece where I'm using data that's already collected to try to understand where in the United States do we have the disparities in mammography screening, which is for breast cancer screening, right? And I'm doing it for the entire United States using secondary data.
Okay.
The second portion is more community-based participatory research, or CBPR, which is where I'm going to be partnering with beauty salons and churches to sit down and engage with women of color to try to figure out what are some of their own personal barriers by talking to them. Facilitators, what are some of the things that are unique to their lived experience in their community that prevent them from even going to get screened, right? This is some of the work that we do. That's the qualitative piece, because it's not going to just be numbers and things that I can just report. Instead, it'll end up being themes and stories that you get based on the conversations that you have.
I was going to say, you could take the number of times you get sort of the same response, and if they list the number of factors,
yes,
you could put so many people said this so many times, and so many people said this factor so many times. Yeah. So that could also give you a little bit of
Chris,
quantitative
you sound like an epidemiologist. You sound like an epidemiologist. That is one way of doing it. So what that would basically be taking the qualitative piece and then quantitatively looking at it. It's a mixed methods approach. So that's definitely feasible. Yes.
Okay. Why so interested in helping the community? Why is that a passion of yours?
Again, my roots. I feel that a lot of it is my roots. And again, being the oldest of grandchildren and having such not a burden, but just this responsibility from an early age that I need to help and serve my community, right? And from a lot of the work that I see, part of it is through my lived experiences and growing up in very underserved communities that don't necessarily have as many resources as other communities do. And even now as a researcher, seeing that some of the same trends exist and persist, you sit there and you're like, well, something needs to be done. And again, I would be, a kid playing basketball, but realizing my surroundings and why are there so many, lack of resources? So a big theme in my work and the research that I do is community partnership and engagement, right? Because we need to reinvest in communities that don't have the resources, and people oftentimes are very receptive. I'm also a member of the 100 Black Men of Augusta, which is a nonprofit organization that focuses on empowerment and upliftment. It's a very huge organization when it comes to mentorship. So we mentor youth between the ages of 8 and 18. And I got involved a lot with the community-based participatory research when I was doing my postdoc in St. Louis, where they were actually doing a lot of these barbershop tours. And it wasn't us performing and going around like as a boy band. No. We went to barbershops to meet people where they are.
Okay.
Right? Because oftentimes when you think about Black men's health, they don't necessarily go get the help that they need until it's too late. Until it's like a critical care type of need, until a loved one says, hey, you need to get that checked out, until something is in cancer, heavily metastasized, and very poor prognosis. So what we were trying to do through a partnership with the 100 Black Men of St. Louis and me as a researcher at WashU and a few other my mentors, we had these barbershop tours where we went to the actual barbershop, right, on Saturdays and would perform health screenings. Disseminate information.
What kind of health screenings?
So we would do blood pressure checks, blood glucose checks. We did waist circumference, BMI, body fat percentage. We even had information about local federally qualified health centers that could help with, more care if they needed that. So we wanted to give as much as we could. So with all that being said, I wanted to continue to do that type of work, which is why when I transitioned here to Augusta 3 years ago, I wanted to be involved with 100 Black Men and continue to do that work, partner with local churches, partner with the local community organizations, again, to meet people where they are, because I don't want to be reactive and just looking at the data and the numbers when we can actually actively be engaged. And there's so many community organizations that have some of the same goals and mission and purpose as we as a medical institution have. As the Georgia Cancer Center, we need to partner and pool those resources.
Yeah.
So it's a passion of mine as a researcher, as a person of color that comes from these communities, that understand the situation, that grew up and did not see. Again, one of the models for the 100 Black Men of Augusta is what they see is what they'll be. I did not see that representation in scientists or doctors. As I was just explaining, I knew I wanted to be a doctor.
But you didn't have.
But I didn't have a roadmap.
Yeah.
Or that guidance.
Yeah.
So I want to be there. Like I focus on cancer disparities, but I have tons of medical students here that are people of color that want to focus on all different types of things. And I'm just there to be a mentor and help guide and make sure that we have the next generation of healthcare professionals that care about these issues that are still here.
Why is mentorship so important? Why are you so passionate about it? Because I can tell from the way you talk about it, you've talked about it a lot, that this is very important to you. How did you find your mentors, and why is mentorship now so important for you?
So mentorship is first important mainly because we need each other to get to the next step. I am a huge proponent of, like, it's a community effort. You know, you have those individuals that think, oh, I can do it all on my own. You know, like even Michael Jordan had a team around him that helped him win that championship.
He was a great basketball player. Right?
But he needed Scottie Pippen and all those other people around him to
true.
become the person, the legend that we know.
Yeah.
And with research, there's not one project that you can do. I mean, you could do, I did my dissertation on my own, but I had my dissertation committee. I had that team around me.
Yeah.
Right? My grandfather that passed away from liver cancer, that was one of my first male mentors that I had that made sure and instilled that passion of science and math in me, right? So that I could feel that I'm competent enough to do it and not feel insecure. Mm-hmm. We're all human, but like it helps you to build those connections and realize that it's attainable. If I want to do something, I can do something. So mentorship is very important just in life in general in order to have the networks that you need to get to the next step. Yeah. Also, I'm not old, I'm just saying, but one thing that's we need to really be cognizant of is that we need to be, mentorship is like a lifelong thing. Right, like I envision that even when I'm 70 years old, I'm still going to be playing the role of mentee and mentor. Okay. Right, you need to be passing that baton. Science does not stop at you. Yeah. Right. I am building from the scholars of yesterday and today. Right. When I do a literature review, that's a part of research. You have to read everything that's been done.
That sounds exciting.
Yeah, and then you have to try to add and contribute to the current body of literature. Right. Mm-hmm. I'm standing on the shoulders of giants. So, and I want to make sure that I'm uplifting the next generation. So that's why it's important in general. I forget, what was the second part of that question?
How did you find your mentors?
How did I find my mentors? Most of them is through, especially given like my, I guess, very limited network coming from my background, is through, a lot of it was, like I was very passionate about something, and then I had like a teacher or an educator who saw that. Okay. Or it was like through relations, right? So like with the mentor at Brown, it was my brother on my dad's side that was from Providence who made that introduction through church. Okay. It's usually through community organizations. It's usually through volunteering, and then people say, "Hey, that kid is going somewhere." That's how it usually happens. It's usually it happens mainly naturally that way, but then it has to be active, right? So if it didn't happen naturally that way, then it was me applying for a certain program or sending a cold email. Hey, this person is doing this. Let me go knock on their office door and talk to them about what I'm interested in. Yeah. And see if I can just steal a few minutes of their time. Yeah. That to me, those are like it's a mix between those two.
Okay. Yeah. So let's talk about what you have found so far when it comes to the color of someone's skin and where they live impacting how long they live after being diagnosed with cancer. What does the data tell you right now?
So I particularly focus on breast cancer. And one of the things that we see in breast cancer is over the past 40, 50 years, due to the advent and the increase in medical technology and screening and therapeutics, radiation treatment, cancer survivorship has increased just overall. We're doing really, really good with our cancer care.
Which is good.
Right? For non-Hispanic white women, survival, 5-year survival, which is like what we usually try to approximate for cancer survivors, is about 91, 92%.
Okay.
That's based on data from the American Cancer Society as of like 2019, 2020.
Okay.
However, for Latino women and non-Hispanic black women, that number is about 79 to 81%.
So about a 10% difference.
Absolute difference, right? So 10% difference just in 5-year survival from the same disease. Now, there are differences in the type of cancer. So for black women, we see that they're more diagnosed with aggressive tumors and triple negative breast cancer, which is not as receptive to some of the treatments that we do have. However, there are so many screening tools in terms of genetic testing to where you can actually you can do 23andMe or some type of DNA test and know if you're predisposed or have a higher risk of being diagnosed with a certain type of cancer. The issue is, again, going back to like structural problems, and this is just my perspective based on the research that I'm doing and how the environment influences certain people. So when we look at breast cancer, we see those disparities. When you look at prostate cancer, we see some of the same disparities comparing black men to white men. When you look at lung is pretty similar in terms of survival. But when you look at various diseases outside of cancer, even when we did COVID-19 in Georgia, we saw some of the same disparities early on. And often it's not. You have people who do the genetic epidemiology, and there are some of the disparities that we do see are explained by variations in genetics. But I don't think a huge proportion of the variation outcomes are explained by that. I think we have to kind of go upstream, look more at what's going on in the environment. One thing that I'm working on now, and this is preliminary and is under review, but there are some other publications that are focused on this. There's this concept that's called allostatic load. Are you familiar with that?
I have not heard of that.
I'm going to explain it.
Please do.
Yes. So allostatic load is a term that was coined in the mid-1990s by medical anthropology scholars, social science scholars, Teresa Seaman and Geronimus and some other scholars. Please forgive me if I forgot a few names.
That's okay.
But essentially what it means, allostatic load, is there is the chronic wear and tear on the body due to life course stress.
Okay.
Right? So essentially what that means is that over your life course, you're exposed to certain events that stress you out. Stress is natural.
Yes.
It's a response that your body has to your environment.
Right.
Okay? And what it does is that there's this neurological system called the hypothalamic pituitary adrenal axis, HPA axis, which is key in your fight or flight response. You've probably heard of that.
I have heard of that before, yes.
You're startled and then you kind of jump, right? And you release a certain chemical or hormone called cortisol.
Yes.
Right? And cortisol can be good, but if you have higher allostatic load or higher stress over your life course, what that does is now you're releasing that hormone at a higher rate.
Okay.
And what happens is you're supposed to have this uptick, and then you're supposed to plateau and go back down after that event, that stimuli. But what we're seeing is, I've published some research that observed that for non-Hispanic blacks, and we can focus on women. For non-Hispanic black women, we compare them, and Latino women, we compare them to non-Hispanic white women, starting at age 20, their allostatic load or their cumulative stress is 40% higher at age 20.
That seems really high.
It is. And then by the time they're, so, and even keep this in mind, allostatic load for non-Hispanic black and Latino women at 20 is comparable to allostatic load for non-Hispanic white women at age 30.
So 10 years later.
Yeah.
Okay.
And what we see is that we see very similar trends in terms of disparities in breast cancer. Like over the life course, it continues to go up because it's associated with age as well.
Yes.
So you see a marked difference between racial groups, and a lot of research does not take into account the historical context of one's environment. There's a reason that Latina and black women may have higher allostatic load, and it's not because they're genetically inferior or something is going on within their bodies. It's the environment and lived experiences that they have to go through. Mm-hmm. So you have allostatic load, which was coined in the 1990s, but there is another term called John Henryism, which was, I believe, coined by Dr. Sherman well before the mid-1990s. And have you ever heard of the story of John Henry?
That name sounds familiar, but
so
you're such a good storyteller. I'm going to let you tell me the story.
I'll be real quick with this one because I'm trying to get back to the disparities and the work that we're doing. But it's related. Uh-huh. So John Henryism is a term that was coined based on the folktale of John Henry.
Okay.
So John Henry, going back to like the early 1900s, late 1800s, that was like the great modernization period when we were building up all the railroads. So we were going, it was like the Western expansion. So we were going out West Coast and we were building all these railroads. But then there was the advent of technology. So you had this famous steam engine, right, that could do the work of about 20 to 50 men in less time.
Okay. Which can be more cost-effective.
Cost-effective as well, right? John Henry, again, this strong African-American man that was a railroad worker. Okay. Right? And he was known as being one of the strongest and most resilient workers, being able to take some of the harshest conditions. And the story basically goes, he was competing against this steam engine to prove that he can do just as good of a job as this new technology.
Oh, wow.
Right? Okay. So the task was to basically drill through basically like this huge mountain of stone. So he's hammering away the steam engine, their head, neck and neck. And he actually beats the steam engine at this task.
Oh, wow.
Amazing.
That is amazing.
Amazing. But once he gets to the finish line, he dies from exhaustion. Okay? So that whole story, when we say John Henryism, is indicative of like the lived experience of African Americans and racial minorities in the country. You have all this certain overwhelming tax or overwhelming expectation of trying to overachieve all of these barriers and circumstances, time and time again. And then you do get to that point, but because of exhaustion from trying to battle something that is insurmountable, you end up depleting yourself physically, emotionally, and mentally. Okay. So again, the John Henryism, from my research, feeds into the allostatic load. Allostatic load essentially means chronic stress. Us in cancer know that if you have any cell under constant stress, it's going to metastasize. It's going to mutate. Mm-hmm. Something is going to happen with those inflammatory cells. Yeah. It's going to cause it to do something it's not supposed to do. Yeah. Which in turn induces earlier onset of diseases or causes certain diseases to be more aggressive. So right now, we've published on allostatic load, just trends over time. We see racial differences. We see, of course, differences over age. And now we've used some data from the NHANES, which is the National Health Administration Nutrition Examination Study. It's a sample of Americans that was funded by the National Center for Health Statistics through the CDC. Okay. And they basically collect data among thousands of Americans every other year, and then they have biomarkers and stuff. So we're able to look at that. And we were able to look at allostatic load among representative sample of U.S. residents, or U.S. population rather. So look at race, allostatic load, and then tie it to cancer mortality.
Okay.
And what we're seeing is that allostatic load is associated with up to 80% increased risk of just dying from cancer when compared to, so high allostatic load compared to someone who has normal or low.
Okay.
And then we see that when you actually stratify or cut it by race groups, there's not as much going on among African Americans, but we do see that non-Hispanic whites who have higher allostatic load have a higher risk of dying from cancer, which could mean one or two things: that we need a bigger sample size and to really look at this in a different study,
Yeah.
or that because of the harsh conditions of like race and an allostatic load, that we can't necessarily tease out the differences. There's still something that's going on. You see the high allostatic load is associated with higher risk, but it's not as marked as 80%. It's like 20%.
Okay.
And again, it's just, we like to look at it as we have these exposures or these things that are in the environment, and we're trying to explain the different outcomes. Oftentimes what happens is in research, we either look for what is the one pill cure, what is the thing that I can intervene, the drug that I can create, right, to give someone.
Yeah.
Or what is the clinical therapy or something that I can do within this setting. And again, as an epidemiologist, our whole framework, our whole thought process is I'm trying to figure out what can we do at a population, a policy standpoint, even if we need to.
Yeah.
Right? Like if we see that there's inequities, then maybe we do need to put a little bit more resources within this population or this community, because that's the only way that we're going to stabilize the differences.
Yeah, and you're looking at it from a local, a state, and a federal level, really, because there's agencies at all levels.
I look at it as, I try to cut it, and that's another thing is I've looked at it nationally, I've looked at it regionally, I looked at it state, I've looked at it within communities, and you continue to see the same trends regardless of outcomes as well. Like again, cancer is not a homogeneous type of disease. There's so many variations in it.
Yeah.
Right? So again, like all the work that we do as scientists is really important, because we need the basic science to really understand what's going on at a molecular level.
Yeah.
But to see, regardless of outcome, that place and race matter so much, there's a problem that we need to address, and we need to really reconsider how we invest in our communities. There's a thing that happens, like when I cut it by, when you look at it by race, you see that certain racial minorities are disproportionately affected. When you look at it by like geography, right? So where you live, if you live in an urban community versus a rural community, those who live in a rural community usually have poorer health outcomes. And this is something that's been happening or starting to spread over the past 30 years. In cancer, we're seeing that if you come from a rural community, you're going to have poorer outcomes. Yeah. And if you have lower income, so if you live in poverty, you have less resources, less opportunity to actually get the care that you need. Yeah. Your insurance coverage is usually contingent upon your job status. So if you don't have a great job that gives you, a low deductible type of insurance, then you're not able to take care of yourself. Yeah. So if you confound that or compound it, I'm sorry. So I'm a gender minority, so I'm a woman, a cisgender woman, I'm black, I'm living in rural America, I have low income. That's fourfold all of the different disadvantages that you have, which are only going to make you more at risk of all of these different health outcomes. Yeah.
Are there certain cancer types where the racial disparities, I know, during my time here at the Cancer Center, I've interviewed a number of subject matter experts about a number of cancers. But are there certain cancers where the disparities are vastly different in the 5-year survival between the different racial groups as well, and also urban versus rural?
Yes, there is, and I wish that I knew this off the top of my head, because we just published one paper that looked at rural-urban differences in lung, prostate, colorectal, and breast. Okay. I will tell you that, I'm trying to remember. I think breast for certain. I don't remember lung being much difference between urban and rural. There is a major difference between lung. You cannot quote me for those four. Now, I will tell you that in Georgia specifically, we do see that certain areas highlight as hotspots or higher risk areas for certain cancer outcomes.
Okay.
So if we focus on Georgia, we do see that rural areas, places that have a high proportion of African American residents and higher poverty, have a higher risk of, regardless of whatever the cancer is,
Okay.
Mortality.
Okay.
Right. So that's breast, colorectal, and prostate,
Okay.
and even lung. Now with lung is really interesting because for rural white Americans, it's pretty, like, smoking prevalence is really, really high. Okay. So that's why you don't necessarily see so much of a racial divide with that one, because the prevalence of smoking is still pretty high.
Okay.
So if you're a rural white American living in Georgia, it's usually like those, like the areas that are like upper northwest Georgia and past like northeast past Athens.
Okay.
Those areas have disproportionate amount of lung cancer mortality. And those are predominantly white communities.
Okay.
And for prostate, colorectal, and breast, the areas that we see for Georgia, again, are predominantly in African American communities. And what's really sad is we see that the hotspots for prostate and colorectal cancer are within the catchment area for the Georgia Cancer Center. So those are within like the CSRA, the Central Savannah River area. Okay. So like right around us. Matter of fact, for colorectal cancer, we do see disparities, market disparities as well. And I feel like I'm all over because there are disparities, yes. Okay. And when you look at certain types, you do see differences. And I'm trying to remember like the figure from American Cancer Society that shows you the absolute difference. Like I told you earlier about breast cancer, it's like a 10% absolute difference. For prostate cancer, I think there's like a greater than 5% difference as well. Okay. But again, just focusing on Georgia, what's really interesting is Richmond County, which is where we are housed as the Georgia Cancer Center. Yes. Is within like the top 5 to 10% of mortality for early onset colorectal cancer. Okay. Now, early onset colorectal cancer is different than your traditional colorectal cancer because it means you're getting diagnosed at an earlier age. Mm-hmm. So like before 40, and you're dying before 50. Again, we're in the top 5%, 10% for the entire nation. Wow. Entire nation. Wow. And when you look at colorectal cancer, just overall, not excluding based on age, Burke County still highlights as one of the highest risks. Okay. What do these counties have in common? Huge proportion of African American residents. There's a huge proportion of what we call food swamps, food deserts, which means that there are areas that don't have fresh produce and fresh foods, a whole bunch of fast food restaurants with pro-inflammatory foods. So resources are very limited. Lower education, lack of resources. But again, we're here as the Cancer Center, but they're not able to receive it because of the disconnect with the community. Mm-hmm. So there's a lot more work that we need to do, of course, as health professionals. But again, when you can just go across the different different diseases in general and see market differences.
Let's talk about some of the programs and some of the outreach, because that is a big part of the work that you do as well as the other members of the Cancer Center's Cancer Prevention, Control, and Population Health Program. Talk about some of the efforts that your team is undertaking to try and meet people where they live. And
so we have, I believe, more than 12 projects currently funded that focus on community outreach and engagement and some type of, again, meeting people where they are to disseminate health information, but then also link people with the resources that they need. I think even over the pandemic, like during the height of COVID-19 pandemic, we still were able to go to more than 20 different community engaged events and hand out information and meet people where they are. One huge project that we have where we're partnered with 20 churches is our C-Care. I believe it's the Cancer Care Awareness, Research, Education project, which is funded by the Bristol Myers Squibb Foundation. Mm-hmm. Huge project. C-Care 2 is where we currently are. Again, we're focused on partnering with 20 churches to help with information on breast, prostate, and multiple myeloma. So what that looks like is not only are we engaged with our patrons within these churches and recruiting almost 600 people, we're giving them information. We're trying to educate them so they can empower themselves to know more about the different diseases, so they can have like a idea of like, okay, like I know that this is going on, this is different in my body. This is something that I can do. Oh, these are some different foods that I can eat, right? That would reduce my risk. And again, we have a lot of resources to where we can partner them here with the Georgia Cancer Center and get screening. So if they need breast mammography, we have that's available for them. That's one huge project. As I was telling you earlier, I have my own NIH grant, which focuses on geographic racial disparities and mammography screening among women of color. And again, I'm doing something very similar where I'm meeting people where they are at beauty salons and churches and recruiting women, about 200 women, to understand what are some of those barriers facilitators. We have the Change Project, which is Dr. Marlo Vernon on our team. She is the PI of. And she's actually partnered with the local Peabody Apartments here in Augusta, where one of the cool things that they've been able to do is create a healthy food store within that apartment complex. Because oftentimes people who live in under resource communities don't necessarily have access. We are here in Augusta, Georgia, and it is a food desert, a food swamp. There is no grocery store within 5 miles.
You have the Peabody Apartments.
None.
Yeah.
So there's, man, and then we have our tobacco cessation team. We have a ton that's going on where right now I think we receive more than 10 referrals, and that's throughout the state. So being able to link people to get help so they can, again, cessation is to help quit tobacco smoking and usage. Let's see, we have a ton of different projects.
So you're talking about these different projects that your team has. You're talking about 800 people enrolled in those 2 different programs specifically. But really, you could be impacting thousands of people because those 800 could tell 1 or 2 or 3 people, and they could tell 1 or 2 or 3 people. So you're really having quite an effect.
If you think about the social network and the passive diffusion of good knowledge and information, if you start with 800 people and we have this entire program of this research study that focuses on the dissemination of cancer health information, you go from 800 within our group, but if they each touch 2 people, then we're at 2,400 people, which is the whole point. We want to meet people where they are. We're all about prevention and control. Oftentimes there's disparities in a lot of different cancers outside of course, some that are more heavily genetic oriented, so your childhood cancers and your leukemias and other types of cancers. But for most solid tumor cancers, there are so many great therapies. Personalized medicine is becoming phenomenal, right? There's immunology therapy, which is growing. And I just did a podcast interviewing someone else on that yesterday. So we're doing the work in terms of the science to actually treat everything. But are we actually disseminating the information?
Yeah.
You can talk to someone within the community, and is very limited knowledge, and this is mainly because we're not teaching this in health ed in high school. And if you don't go to college and don't take a health course or a biology course, then when else are you going to learn it? When?
Yeah.
It needs to be some type of investment within our populations. So oftentimes what happens is, again, based on your job security, based on your income, that's going to be contingent upon your health insurance, which means that then you may have a rapport with a doctor, a primary care physician. You can have these conversations. If you don't have a primary care physician that looks like you, then you may not feel comfortable telling the information, right?
Yeah.
Or sharing information, or you may hide something, or you may have certain type of alertness when you're getting treated. Again, we're trying to develop that rapport with our community. There's warranted reason behind why so many marginalized communities do not trust healthcare systems, the United States at large.
Yeah.
We saw very well so during the height of the COVID-19 pandemic, that there's so much mistrust among marginalized communities because of historically what has happened. Everything from Henrietta Lacks to the Tuskegee experiments to current medical racism that a lot of people have experienced personally. There's medical trauma for people who are of the LGBTQ community, not feeling that they can go to a certain place and get treated.
Yeah.
Because of being judged and feeling ostracized.
Yeah.
So there's so much work that we have to do in terms of building that community bond and then empowering people to know the correct information. Because oftentimes we don't get it right. In science, it's a learning algorithm. We have information that we had before and we want to build from that. And we need to be transparent with what we do know.
Yeah.
Again, so the fact that we're able to help those 800, and then hopefully there's going to be more people that want to continue to work with us based on the relationship that we establish. But a lot of it is about sustainability. So I'm not always going to be here. Dr. Tension on our team, who's wonderful, is not always going to be here. You're not always going to be here. It's about that mentorship thing and passing on the baton that I was talking about earlier.
Yeah.
What are we doing to reinvest so that the next generation of people know better?
Yeah.
Right? So we may be disseminating some information in terms of like healthy food behaviors and consumption, right, among the parents, but they've ate a certain way for 40 years.
Yeah.
But maybe we can try to instill or impart some type of knowledge on, hey, maybe you want to get these types of produce for your children.
Yeah.
So they can develop healthy habits.
Yeah.
And then their risk is lower.
Yeah.
Right? So that's what it's about. It's about empowerment, sustainability, working together as a community. And that's a lot of the work that we do here within our program.
What would you say, your one or two key messages are for people when it comes to their health and cancer prevention, no matter where they live or the color of their skin? What would your messages be to them?
On a personal note, the first message would be to invest in your health. That's the number. When I say invest in your health, that's the most important investment that you can make, right? So understanding that certain diets have certain risks that are involved. If you consume a more of a southern-based dietary pattern, then you're more at risk of dying from cancer. That's just what the data suggests. If you consume and drink more alcohol, then you're more likely to die from certain types of cancer. So I guess it would be to invest in your health and to understand that the dose makes the poison.
Okay.
Too much of anything can be bad for you.
Yes.
So balance it. Life is about, I want you to live. I'm not saying, hey, you got to sit back and you can't do nothing.
Yeah.
No, but I'm saying.
They always talk about moderation.
Yes. Like, no, you don't want moderation in fentanyl. That would kill you. We're talking about, like, it's the dose. It's the dose. It's the dose for sure.
Yeah.
In epidemiology, Paracelsus, it goes, the dose makes the poison.
Okay.
So again, just really consider that in your day-to-day. We come to work and we may work for 12 hours. What are you doing for yourself? You may sit down and stress and then eat and then what have you done? Like, because if you're not investing in yourself, you get up, walk, move, get some sunlight. It's important. Vitamin D.
Yes.
Like those things, invest in your health. That's the number one thing that I can, on an individual level. Another component of that may be a champion for yourself. You need to invest. I've had countless number of cancer survivors say, I went to this practitioner and they said, oh, there's nothing wrong with you. And I went over here and they said, no, but I knew something was wrong with my body. Yeah. Be a champion for yourself. No one else is going to care about you more than anyone else. That's the first thing. Mm-hmm. So that's more of the internal suggestion that I would have, or the personal suggestion. But in terms of more of a societal approach, we need to be more cognizant of other people's lived experiences. Mm-hmm. We all have certain privileges. We all do. Yeah. We live in one of the greatest countries in the world.
Yes, we do.
We are much so privileged compared to other people in their circumstances. Yeah. But we all have a certain journey or in a certain point in life. I know this is more philosophical than this, but like it has a lot to do with a lot of the problems that I see in the data are suggesting that certain minorities are disproportionately influenced by stress.
Well, and what you've talked about a lot is those, or are those, community connections, and making those connections with your community, whether it's your neighborhood, your city, your church, your friend group, your social groups. Like, it's all about connection.
Yeah. And we need more positive connections. So I just want people to be more cognizant of how we treat other people and what role can we play in making for, like, I feel like I sound like Michael Jackson, make it a better place for you and for me. But that's more of the, like, when I look at it, I'm like, yo, like, a lot of these problems that we see, you know, like, we really need to, like, and that can be for us as an institution. How are we treating our patients? How do they feel when they come in? How convenient is parking? You know, like, we want that to be a pleasant experience, because what if it was you or your mom or your loved one that was getting that care? Right? Same
that makes
thing.
sense.
Yeah. So it's just, again, like, personal note, invest in yourself. The dose makes the poison. And then from a societal note, we need not try to make things difficult for other people's lives, because we have the power to do so. So.
Well, Dr. Moore, I appreciate you taking the time to sit down with me today to discuss what it is that an epidemiologist does, and share your passion and your dedication with those watching and or listening today. Remember that you can follow, rate, review, subscribe. You can find A Cancer Conversation on YouTube, on the Georgia Cancer Center's YouTube channel. You can follow us on Apple's podcast, Google's podcast, and Spotify. So lots of different options. And thank you again. We will
Chris.
see y'all next time.
Chris, I just want to drop one thing. You probably already closed it out, but please follow me on Twitter.
Okay.
real_DrJSM.
Okay.
I think that's it. So just
one more
me.
time.
Follow me on Twitter, on social media at real_DrJSM.
Okay.
Yep.
All right. Thank you, sir.
Thank you. It was pleasant.
Absolutely. Y'all have a good day.